Hello, this is Michael Gorin from Cumberland, Maryland, and now I'll be giving a talk entitled Recent Advances in MRI-Guided Prostate Biopsy, a Focus on the Transperineal Approach. Again, first disclosures. Relevant to this talk, I am a paid consultant to BK Medical, Corbin Clinical Resources, also known as Perineologic, maker of the PrecisionPoint Transperineal Access System, and KOELIS Incorporated. Although it feels like it's been a long time, it was not too long ago that the evidence really came into focus supporting the use of multiparametric MRI prior to performing prostate biopsies. The study which demonstrated the improvement in clinically significant cancer detection was the PROMISE trial, which was published in Lancet in 2017. In this study, patients underwent a multiparametric MRI of the prostate, followed by a saturation prostate biopsy as well as a transrectal ultrasound-guided prostate biopsy. The authors then compared the diagnostic performance of multiparametric MRI to truss biopsy using saturation as the gold standard for diagnosing clinically significant prostate cancer. What these authors found is that multiparametric MRI had a sensitivity of 88% for detecting clinically significant prostate cancer, whereas truss biopsy had a sensitivity of nearly half that much at 48%. Based on these results, it became clear that multiparametric MRI could be used prior to prostate biopsy to improve the overall sensitivity of a biopsy for detecting clinically significant prostate cancer. Around the same time, technical advancements came about which for the first time allowed urologists to fuse the images from multiparametric MRI to a real-time transrectal ultrasound, allowing for the guidance of biopsy needles to lesions of concern. The first biopsy system that was widely used for this purpose was the UroNav system, which was developed initially by Peter Pinto and co-workers at the National Cancer Institute. Using this system, the team at the National Cancer Institute were able to demonstrate an improved detection of prostate cancer when MRI targeting is employed. In this study by Siddiqui et al. Published in JAMA, the authors found a sensitivity for clinically significant prostate cancer detection of 77% when MRI targeting is used. In contrast, sextant biopsy had a sensitivity of only 53%. When these two forms of biopsy were combined, the overall sensitivity for clinically significant prostate cancer was 85%. This translated to significant improvements in the area under the curve for targeted MRI-guided biopsy for detecting clinically significant prostate cancer. Diving a bit deeper into the data by Siddiqui and co-workers, we could see that approximately 14% of men with either no or only grade group 1 prostate cancer on a 12-core biopsy were found to have clinically significant or grade group 2 or higher prostate cancer on their MRI fusion biopsy. Importantly, one cannot simply replace a systematic biopsy with an MRI-targeted biopsy because approximately 7% of men who had no or grade group 1 prostate cancer on their MRI target were found to have grade group 2 or higher on their 12-core biopsy. In a later cohort published by this same group, we see very similar results. On systematic biopsy alone, the overall cancer detection rate was 52.5%. In contrast, the cancer detection rate when the systematic and targeted biopsies are combined increases to 62.4%. And it's worth noting that the majority of the difference between these two groups was due to an improvement in the detection of clinically significant prostate cancers, that is, cancers which are grade group 2 and higher. We now have level 1 evidence to demonstrate the superiority of MRI-guided prostate biopsy to systematic biopsy alone. This is a meta-analysis published by Goldberg and co-workers in the Journal of Urology in 2020, which incorporated 5 separate randomized controlled trials comparing MRI-targeted biopsy to systematic biopsy. Overall, it was found that MRI-guided prostate biopsy leads to an approximately 11% improvement in the detection of clinically significant prostate cancer relative to if a systematic biopsy was performed alone. As a result of these data, the American Urological Association now endorses the use of pre-biopsy MRI. Previously, this recommendation was only limited to men with a negative prior biopsy and ongoing concerns about their increased risk of prostate cancer by a rising PSA level. However, in their most recent recommendation, published in the Journal of Urology in 2020, they state that sufficient data now exists to support the recommendation of magnetic resonance imaging before prostate biopsy in all men who have no history of biopsy. So based on the data presented in my earlier talk, we know that there is a marked decreased risk in infectious complications with the transperineal approach. Again, with the transrectal approach, there seems to be a risk of sepsis in the range of approximately 0.8%. In contrast, when the transperineal approach is employed, this risk decreases to 0.1%. Because of these infection avoidance benefits, it is my opinion that transperineal prostate biopsy should be the standard of care when assessing a man for prostate cancer. In addition to this, however, there does seem to be benefits in terms of cancer detection, in particularly when MRI targeting is employed. As I showed earlier, that we have the study from Baer and co-workers that showed an approximately 15% increase in the detection of clinically significant prostate cancer when transperineal versus transrectal MRI targeted biopsy is performed. We also have the study from Pepe and co-workers where the authors performed saturation biopsy as well as transrectal and transperineal targeted biopsy of patients. Saturation biopsy serves as the gold standard to which the results of the transrectal or transperineal biopsies were compared. The authors found it improved sensitivity to 93% versus 66.7% for the transperineal approach overall for detecting clinically significant prostate cancer. And much of this difference was due to improved sampling of anterior zone cancers. So what are the methods for performing MRI-guided transperineal prostate biopsy? Well, the first method I wish to talk about is what's known as the cognitive targeting or the visual estimation approach. One benefit of this approach is this does not require a fancy purpose-built fusion system, so the cost for this fusion system beyond simply owning an ultrasound is free. To date, there have been a handful of reports demonstrating the diagnostic performance of the cognitive or visual estimation approach for performing transperineal prostate biopsy. Several of these papers employed the PrecisionPoint transperineal access system. As I showed in my prior talk, aids at performing freehand transperineal prostate biopsy under local anesthesia. A key component of the technique using the PrecisionPoint device is the use of biplanar transrectal ultrasound. The papers, which I'll share with you in a moment, all employed BK ultrasound units, and all modern BK ultrasound units employ both a linear and a curved ultrasound array on their ultrasound probe. And because of this, simultaneously, the user is able to visualize the prostate both sagittally and as well as in the transverse planes. And so because the user is able to see both planes of view at the same time, one is able to steer the needle very precisely into regions of interest that the urologist viewed on preoperative MRI. In this paper by my group, which was published in the World Journal of Urology, we demonstrated that using the PrecisionPoint device along with cognitive fusion allowed for excellent prostate cancer detection rates. We see that among PIRADS 5 lesions, our overall cancer detection rate was 92%. Looking at PIRADS 4 lesions, it was up over 60%, and for PIRADS 3 lesions, it was over 36%. The majority of lesions in both the PIRADS 5 and PIRADS 4 groups were clinically significant grade group 2 or higher prostate cancer, and 50% of cancers in the PIRADS 3 group was grade group 2 prostate cancer. We are not alone in our observation. There were also papers published by Lopez and co-workers and Neal and co-workers. Both of these papers are from the United Kingdom, where they had large numbers of men who underwent cognitive fusion transperineal prostate biopsy using the PrecisionPoint device, and they found similar, if not better, overall and clinically significant cancer detection rates using cognitive fusion with the PrecisionPoint needle guide. There are, however, downsides to performing cognitive fusion biopsy, and that is that there's no mapping of cores. Here in this image, we could see that if a prostate biopsy is performed using a proper fusion system, the user can then record the precise locations of not only the prostate, but also the MRI target and each individual biopsy core. Why is mapping important? Well, this allows the user to review post-game footage of the biopsy to see if they actually hit the targets. Imagine an MRI-guided biopsy is performed and it comes back without any prostate cancer found. Well, if you have a record of where your biopsy needles were, you could then go back to those images and see, did you really hit the target? Perhaps there was a misregistration, etc. Mapping is also important because it helps with performing repeat biopsies for patients who are in active surveillance for prostate cancer. Perhaps the urologist wants to resample areas which were previously biopsied at an earlier point in active surveillance. Or perhaps the urologist wishes to avoid those areas and biopsy new areas of the gland to improve overall sampling density of the prostate. Additionally, mapping allows for greater confidence when performing nerve-sparing radical prostatectomy. If the urologist knows where precisely the cancer was found relative to the contour of the gland, they could then perform a more customized nerve-sparing approach. Finally, mapping is important because it opens the door to performance of focal therapy. Again, if the urologist knows the precise locations of the prostate cancer, if that cancer is limited to, say, one or two small areas of the gland, then you could go back and at a later date selectively ablate those areas. So a number of purpose-built fusion systems are currently available on the market for performing transperineal prostate biopsy. And here are the major ones that are currently on the market. These include the UroNav platform, the Artemis system, BK Fusion, the KOELIS Trinity, and the biopsy platform. There are some differences, however, in how the biopsies are actually performed. As you may recall from my earlier talk, I spoke about the grid and freehand-based approaches to transperineal prostate biopsy. Well, for instance, the UroNav system allows for both grid and freehand. In contrast, the biopsy system only allows for grid. These units in the middle, they allow for a mixture of different approaches. The Artemis system, for instance, uses a mini grid, which is not quite a full grid, but rather just one single column of a grid. The BK Fusion system has both a grid and a freehand option, and the KOELIS has the full range of options of a grid, a mini grid, and also the freehand-based approach. There are some newer systems as well on the market that add to this list, and that includes the ExactView micro-ultrasound unit, which allows for transperineal to be performed, as well as the system from Focal Healthcare. Among the systems, there are three which are currently compatible with the PrecisionPoint device, and those include the UroNav platform, BK Fusion, and KOELIS, and these are the three systems that allow for a freehand-based approach. This slide shows a table summarizing the various biopsy platforms which are available. I list here the methods of needle tracking that are performed, as well as the types of transperineal prostate biopsy that can be performed with these systems and whether or not they're compatible with the PrecisionPoint needle guide. Here are just some images demonstrating what one of these biopsies looks like. This biopsy was performed using the PrecisionPoint needle guide and the BK Fusion system. It uses electromagnetic tracking to keep track of the lesion and in the prostate contour during the procedure. And here you could see the biopsy core being directed into the MRI target. And then after the procedure, the biopsy contour and lesion have been fused back to the MRI, and the precise locations of all of these biopsy needles have now been overlaid on the T2 images. This is a similar image demonstrating the same point using the KOELIS Trinity biopsy platform. The KOELIS Trinity uses a novel form of needle tracking that relies on image-to-image fusion using 3D ultrasound. Here you can see a live sagittal display of the prostate with the needle core being directed into the region of interest. And on a 3D volume to the left here, we could see prior biopsy cores mapped on top of that lesion. After the case, we could do full prostate cartography or mapping of where our individual needle cores are relative to the lesion, and you could see that this is a very complex three-dimensional diagram, and with this information the user should have no doubt of where the prostate cancer was present at the time of the biopsy relative to their needle core location. So in conclusion, use of pre-biopsy multiparametric MRI improves the overall detection of all grade and clinically significant prostate cancer. MRI-guided prostate biopsy should ideally be performed with the transperineal approach, which offers the key advantages of infection avoidance and superior cancer detection rates. MRI-guided transperineal prostate biopsy can be adequately performed with cognitive fusion, also known as visual estimation, and I have shown you the results of 3 separate series demonstrating this using biplanar ultrasound guidance with the PrecisionPoint transperineal access system. There are, however, a number of purpose-built fusion biopsy platforms which now exist for performing MRI-guided prostate biopsy with the transperineal approach, allowing the user to, in a highly accurate manner, track needle locations within the prostate gland and relative to MRI targets. Again, I'd like to say thank you to the meeting organizers.